So before we start with the questions and answers, I want to thank all the speakers for their wonderful talks. I want to thank Iridex for giving this opportunity to us to speak about this technique. And if anybody has a question, now is the chance. Please go to the microphone. It's easier for everybody.
So first of all, any cases of phthisis bulbi?
No.
What is the longest follow-up for this procedure?
This, I presented this 78 months.
Any experience with local retrobulbar anesthesia? We don't work with a lot of anesthesiologists, so we'd be interested to do this just with retrobulbar.
Yeah, you definitely can do that. If you do any kind of anesthesia that you inject something, I know retrobulbar shouldn't be like that, but it can happen. Be aware if the anesthesia fluid is a little bit far at the front near the limbus, you have maybe some problems to place the laser. So maybe you need to push the fluid a little bit backwards if it's coming forward, especially if you do subconjunctival or peribulbar. With retrobulbar, should be fine.
Thank you.
Can you explain, please, how the retina MicroPulse laser is applied? Can you explain, please, how the retinal MicroPulse laser is applied?
There is a relatively standard treatment recommendation by Iridex, which you can, when you start out, I'd suggest you follow. So initially you need to create a barely threshold burn. And then they give you a standard setting of 200 milliseconds, and then I tend to start at 60 milliwatts, at 200 micrometer spot size at the retina. And then typically I find that most Caucasian patients end up being somewhere between 60 to 80 milliwatts, and then you take that power setting and multiply by 4 and put it into a 5% duty cycle, so that if you say have a 60 milliwatt threshold burn, then you would end up with a 240 milliwatt at 5% duty cycle, 200 milliseconds, 200 micrometer burn. And then essentially the settings that Iridex gives you is a confluent 7x7 that is 49 spots per grid, and then you do 8 grids around the fovea. But in my experience, you can also do the fovea once you really gain your experience with the device. We've actually had quite good results doing transfoveal treatments as well. Does that answer your question?
Partly.
Okay.
And but you don't do it endoscopically. You do it by a slit lamp.
Wait, are you talking retina or
the retinal?
Why would you need an endoscope for the retina?
But is it the same Iridex you use?
No. This is a completely different device.
Yeah.
Okay, so these are two different devices. The cyclophotocoagulation device is a different device from the 507 Iridex yellow laser for maculas for retinal procedures.
Thank you. And then I have a second question, if it's allowed, to Dr. Siemierski. You said something about the visual loss after the laser treatment of the ciliary body. What's your experience? Is it a great visual loss, a small visual loss, some people, or how?
It's most commonly no visual loss. In the studies that we did, the patients with the good central visual acuity, we had 13% of patients lost 2 or more lines, and those were mostly attributed to CME.
Yeah. Thank you.
Hello, very interesting session. I would just like to ask about whether you have any experience using the MicroPulse for congenital glaucoma, for ophthalmic eyes. Would you recommend?
I wouldn't. I tried it because the idea is kind of appealing. You have a laser with less inflammation, so it should be really nice. In a kid with this, always a problem with a lot of inflammation at all. But the younger the patients are, especially if we talk about babies, the results are good in the beginning, but they don't last forever. And that's also published.
Right. I have a patient, she's ophthalmic, she lost one eye, and she's refusing any kind of surgeries whatsoever for the other eye, and it's somewhere around 28 on maximum treatment. So she was asking about the option of having the new laser, which is the MicroPulse.
I guess I see no reason why you can't try it. Just one word of advice about ophthalmic eye using transclear laser. Please do retro illumination to find out roughly where the ciliary body is, and then perhaps mark it. It will be more than 3 millimeter or 4 millimeter behind the limbus. It will be, because it is ophthalmic eye. So do a proper retro illumination, mark where the ciliary body is before you do the laser. But I think the fact that he or she is refusing any surgical treatment, I would do it.
Yeah.
I'll try it. Why not?
I mean, the point is you have nothing to lose. If you don't do anything, she has a problem. The point with the marking is really a good point, because you need to know where to apply the laser and mark it at different clock hours, because there's a lot of variation even within one eye where the ciliary body is located. It's not always at the same distance from the limbus all around the eye.
All right, just one last question for the same patient. She has a scarred, old, fibrosed trab. Would you recommend that we could apply on it, sweep on it? Yeah. All right, thank you.
Regarding the location of the Iridex, I got different advices to place the notch in the probe on the limbus, and then I heard place it 1 millimeter behind the limbus. Do you mark the...
I always do transillumination for every patient, roughly see where their ciliary body is. If they are not unusual, they're usually 3 millimeter behind the limbus, so that's fine. The notch to the laser delivery will be 3 millimeters, so you can go all the way around. If you have a slightly unusual anatomical eye, mark it, and you may want to move it a little bit behind the limbus before you start the treatment. So it depends on the anatomy of the eye. Just do a transillumination, retroillumination quickly, see where they are.
Is that, do you have the same experience?
There's a lot of variation at the moment how colleagues treat with the MicroPulse technology. Some people use longer cycles, as the 80 seconds, some use more energy or less energy, and there's also some colleagues who now titrate a little bit further away from the limbus than the marking is. But with the retroillumination, you're always on a safe play that you know where the anatomy is in this eye, what you want to treat. We don't know for sure what's the best place at the moment.
Thank you for the wonderful lectures. Number one, I have lots of, many of my patients are angle closure. It's very prevalent in my country. And at times when we do phaco, I mean, it drops their pressure. So my question is, do you think that doing MicroPulse has any added value for angle closure patients undergoing phaco?
We were talking last night, actually, about doing phaco combined with MicroPulse. I have not done that myself, but I would think, you know, if people have angle closure and using ECP to rotate the ciliary body posteriorly as well as doing the phaco would be a very nice effect. I don't know if that's going to, MicroPulse is going to be as effective at moving the ciliary body or contracting the ciliary body posteriorly, seeing that there have been studies that morphologically look at the ciliary body and the angle with UBM, and there was no change.
Yeah.
I haven't got any data yet to show you, but I've just, for primary angle closure glaucoma, I used to do phaco, goniosinic glysis, and ECP, they say all three at the same time. So I just moved to phaco and goniosinic glysis, if there's significant PS, and MicroPulse laser. I've just changed that about a month ago, so I can't tell you what the result might be, but certainly that's what I would do.
I'll be eager to hear the results of your experience. The second question is, I use peribulbar, sometimes retrobulbar, with depending on the patient. Sometimes I feel the patients are not feeling the laser, but it's the notch, that edge in the center of the probe that hurts him a lot, especially when we move it. So number one, what techniques, what caveats you have to tell us to overcome this problem? The second question is, to overcome this problem with some of those patients, I had to do like very small movements, deliver small movements. Do you think this is still effective?
Okay, regarding the tip of the probe design, don't worry about it, because we are working on a new probe now with Iridex, so we will have a new probe coming out very, very soon, without that little notch, which is quite uncomfortable, as you say. It causes sort of a subconjunctival hemorrhage.
Yes.
But and the tip of the probe will also be much smaller. So watch this space. We literally just got a draft drawing of the technical drawing of the new probe last night, and I'm going to try out a new probe within the next maybe 2 to 3 months on some cadaveric eye. We're hoping maybe next year we will have the new probe out, so which will be smaller without that protrusion that causes problem.
I'm sorry to break up the discussion, but the room will be used again in a couple of minutes. Be aware there's always an expert at certain times at the Iridex booth for retina and also glaucoma, willing to answer a lot of questions if there are still some. Thanks everybody for being here.
I'll be at the Iridex booth now, actually, for an hour.
Perfect.